Hello, everyone, and welcome to the Caring and Living as Neighbors side event at the 77th World Health Assembly. Today, we have experts joining us to present what will it take to scale newborn screening so that every newborn has an equal chance to life and health. We would like to acknowledge the lands from which everyone is joining today. I am presenting from the lands of the Lenape people as I am based in Bethlehem, Pennsylvania of the United States. I pay respect to elders past, present, and emerging. As Clan is based in Australia, we acknowledge the traditional owners of country throughout Australia and recognize their continuing connection to land, waters, and community. Our speakers today are presenting from Geneva, Switzerland, and we recognize the traditional owners of the land, the Helvetii people. We pay our respect to First Nations people internationally and to their cultures and elders past, present, and future. I'd like to introduce Professor Diane Webster. She will be the MC of our event today. Diane is the Vice President of the International Society for Neonatal Screening. Thank you for your support, Diane. Next, our online facilitation team is comprised of Dr. Kate Armstrong, who is the president of CLAN and co-founder of Mates for Kids, alongside members of the youth team, Katie Blomquist and Mabel Cudmore. Katie is one of our UN youth representatives as well as the Mates for Kids project officer. Mabel is the community development officer for CLAN. We would like to recognize all of our collaborators for this event. None of this would have been possible without working together with valuable stakeholders and building new connections to scale newborn screening for all. Thank you for all of your contributions. Next, we would like to recognize our sponsors of this event. Each of our sponsors are doing groundbreaking work for newborn screening globally, and we thank them for supporting our event at the World Health Assembly. Now we will be hearing a word from one of our sponsors, Revity.
From working with the newborn screening laboratories for over 4 decades in over 110 countries. That's given us time and expertise to develop the complete product offerings to fulfill the needs of different type of newborn screening laboratories. At Revity, we are here to help you, making sure that the process runs smoothly and precisely at every stage. Due to our long-term history and our specialized knowledge, expertise, support, and technologies, laboratories can quickly develop the skills and confidence they need to deliver accurate and fast results. This also enables parents to rapidly receive the clean bill of health for their child and allow health professionals to start any appropriate treatment as early as possible. This gives me a great opportunity to invite you all to join Worldview International Newborn Screening Summit. The event will be live streamed across the world June 11th to June 13th. This also gives a unique opportunity for the whole newborn screening community to share, learn, and develop, share their own, share their kind of own learnings, best practices, and develop the program further. Revity card with a QR code. Those are on the table behind, and sign up for today. So to finish, I'd like to kind of remind that screening is the best possible preventive healthcare. At Revity, we are committed to building capacity needing for the national coverage. We provide you the tools to run a successful and cost-effective newborn screening programs. As national program, such as newborn screening should leave no one behind.
I was born with this medical problem that can make it difficult to walk.
I don't really know what they called, but I guess it's kind of scary.
My dad says it can hurt your brain, so you can't really learn.
I think you can even die from it.
But I won't. I won't.
I won't either.
All around the world, children born with health issues like hypothyroidism, sickle cell disease, and PKU are having a new outlook on life. That's because Revity is working with governments and healthcare providers to bring newborn screening solutions to their communities, helping to save about 75 precious lives per day. With just a small blood sample at birth, this life-saving technology can detect over 50 health disorders early enough for doctors to treat or manage them. So any child born with a deadly or disabling health issue has a better chance of beating it, creating a healthier humankind.
Thank you so much.
Thank you, Marika. And it's now my pleasure to welcome Samir Saral from Lab Systems to tell us a little about Lab Systems. Oops, forward.
Okay.
Into the screen.
Hi, good afternoon, everybody. It's a pleasure and privilege to be here with some of the big names of newborn screening, international and global. I have 2 minutes, I think, so let me just quickly cut to the chase. We have been also in newborn screening for a fairly long time, almost 3 decades of presence, and I'm quickly running through some of the activities and the products that we have. So we are based at a city called Vantaa. It's a suburb of Helsinki, and about 30 years since we've been in this field. And we do all our activities at one location in Vantaa, where we are headquartered. And we have a range of products for newborn screening, which is fluorescence-based kits and instruments. There are some brochures on the side. If you're interested, you could pick up those. We also have the other products for LCMS, for mass spectrometry, and for PCR. There are some other products not relevant, but just to know that we also have a few other products. And in some cases, we have always tried to be in the forefront of bringing an advantage to the fraternity, because there are certain disorders which are quite prevalent, but probably not diagnosed or not detected. So we have the complete cycle, the proximal variants for the cycle disorder. We also have the hidden SMN kit, where we have SMN2, which tells you about the severity of spinal muscular dystrophy. We have unique products for hyperplasia second-tier testing, because it's quite common to have false positive in this, and this has been quite a demand or a need of the market. So having brought that, we feel there's a lot of benefit in differentiating between the too many false positives and actual positives for CAH. So these are things which we offer to the newborn screening community, and we try to differentiate ourselves from the rest. And having been in this line for almost 30 years, it's also our duty to offer something that the market needs. It's not about trying to sell what we have, but we are also committed to the cause, and we try to have products which might benefit the community. And therefore, we invest a lot in R&D. We are trying to come up with new products and or new different assays which might benefit. And on the same lines, we are now looking at some new technologies. Of course, it's no longer that new, but next generation sequencing, we have a few panels for lysosomal storage disorders. We're also looking at specific assays on fluorescence for different variations, different disorders of lysosomal storage. And sickle cell disease, of course, it's been around for a while, but for us, it's relatively new. We are coming up with a new product for that. And I can leave my contact details with those of you who are interested. But thanks for this opportunity, and have to congratulate the WHA for doing such a great job. Thanks.
Thank you very much, Samia and Marika. I'd just like to talk to you myself for a few minutes about newborn screening, because there's some people that think newborn screening is a lab activity, and to some extent it is, but there's quite a whole lot more involved. I come from very small islands at the bottom of the world with a very small, relatively speaking, number of births, 60,000, but we've had full national coverage of newborn screening since 1969. So, and I've been involved since the 1980s. So that gives me a bit of experience in how we make a whole program. We can think about newborn screening as a program, but thinking of it as a program is a bit like I love you, or I've been consulting. It means what's in my head when I say it, and it means what's in your head when you hear it. And they're not always the same thing. We can think about newborn screening as a pathway, and that's the series of steps that somebody goes through when they are being screened. So it's the offer, it's the test, it's the testing, it's the reporting, and it's the follow-up. But we need to think about why we're screening. And we're screening for hypothyroidism. Okay, that's right. Are we screening to find high levels of TSH? Are we screening to find babies that might have hypothyroidism? Babies that do have hypothyroidism? Are we screening so we can treat them early? And in fact, none of those things are really why we're screening. We're really screening so that our children with hypothyroidism meet their growth and development potential. And that needs more than a screening pathway, and it needs more than what most people call a screening program. What it needs is a screening system, and that's all the components that are required to set up newborn screening. It's somebody who thinks about what we're going to do, how we're going to do it, how we're going to fund it, how we're going to tell if we're doing a good job at it, how we're going to be watching all the different aspects of it. And the different aspects of baby-centered and newborn screening system are shown here. And you can see that they are things that are largely under the control of healthcare professionals. And that's what some people would call your screening program. So they're the laboratory and the follow-up and collecting the samples. But there's also the things which are perhaps not so much in control. And one of the things that's really critically important to getting good outcome for screened babies is their family, because they bring the baby to healthcare. They agree to have the baby screened in the first place, and they give the baby its medicine. So all of those we need for screening. Professor Neil Bust has a nice analogy in which he says that one broken link makes the whole necklace fall apart. So one part of the screening system that doesn't work means that our babies are not likely to grow up tall and smart as we would like them to. So my big message is successful newborn screening takes a system. It takes us all. Newborn screening takes us all. And that's my big message for you today. And now I would like to introduce Professor Aisha Habib Khan. She's from the Aga Khan University in Karachi in Pakistan. She's the co-chair of the International Society for Neonatal Screening, International Federation of Clinical Chemistry Joint Task Force on Newborn Screening, and she is also the treasurer of the International Society for Neonatal Screening. Professor Khan.
Thank you. Thank you, Diane, for your kind introduction, and also for giving a very comprehensive, knowledge about the NBS system. So with this, good afternoon, everyone, and good afternoon to all those who have joined on Zoom as well. So that I'll talk about the global horizon of newborn screening, and we'll be sharing with you the there's some exciting initiatives that has been going on for bridging gaps and developing synergies for universal health advancement across regions and countries. So I have nothing to disclose. And here is an outline of my presentation, and I'll talk about the global status on newborn screening, and will update you on the working and progress of a joint initiative by IFCC and ISN. And then, using example of Pakistan, I will talk about the barriers and challenges that are encountered in implementing a newborn screening program or a system or a pathway. Then finally, I will talk about the recommendations and way forward for developing for future developments, and including a new initiative by ISNS for developing a global newborn screening map for keeping track of activities around the world. So newborn screening beyond the spot and in line with WHA 77 agenda, universal newborn screening programs can help improve outcomes, and that is because by early management, diagnosis, and management of treatable childhood non-communicable diseases. While these programs are very well established in upper income countries, many lower middle and even some upper middle income countries also do not have universal newborn screening, and they have unacceptable outcomes. So there is considerable interest in scaling up newborn screening activities to achieve the United Nations SDGs goal by 2030, provided that this newborn screening is done ethically and safely in low with cost-effective conditions, because the access to these treatment and everything can be very expensive in low-resource setups. So here is a map of and the current landscape of newborn screening, which is globally. And as you can appreciate here, there's wide variation in the panels and the policies that are adapted around the world. And this is because of the disparity in the healthcare systems, the healthcare capabilities around the world, and the different panels, and that's why that they are being, there is wide variation. And according to a United Nations estimates, around 32% from an estimated 140 million babies born each year undergo screening every year. So there's much to achieve. Then this is a snapshot of Asia-Pacific region. And as you can see, there's variation in this Asia-Pacific region as well, with some countries achieving 100% coverage, whereas there are countries which are far behind. And it is these countries that require support from international agencies, as well as, more importantly, they require support from their own governments in bringing and improving outcomes. So I thought of sharing this review article, which was published only day before yesterday. And this is a very comprehensive review. This is a very comprehensive review. This is what has happened. The view has gone. So this is a very comprehensive. So this screen has changed. Yeah. So this review that was published day before yesterday and gave a comprehensive review of recent activities going on around the world in area of newborn screening. And I have just taken an excerpt from this manuscript, and it quotes, and I have quoted it here. It is the responsibility of experts and companies experienced in current newborn screening applications, who are usually from high income settings, to assist developing programs in lower income or LMICs or LMICs. So, with this philosophy, a joint task force on global newborn screening was set up in 2021. The idea was to help develop appropriate screening programs worldwide through support networking. And this support networking was by engaging local advocates and key national health policy makers, and then by supporting them to develop pilot projects and conduct these pilot projects. And for those countries where pilot projects have not been done, then to facilitate sustainable, where pilot projects are already there. So to facilitate them in developing sustainable national funded programs. So the task force set the stage by creating awareness and education, which was across the IFCC network of national societies and ISNS network. And then the task force performed a need assessment survey, and in 2021, and out of 425 responses were received from 84 countries across IFCC and ISN network. And this helped the task force to identify areas where the focus should be. The top 4 disorders identified across the world included congenital hypothyroidism, PKU, CAH, and CF. And 92% of these countries were using a dried blood spot specimen. Then then there was an overwhelming response from 92% of the responders of requiring support with regard to education, training of laboratory and personnel and clinical personnel, and quality-related activities. So the potential IFCC, ISN, potential partner countries were identified, and a list of those countries were made. And virtual meetings were held to getting orientation to the newborn screening journey through in these countries. A template for Zoom was made to get the information, and preference was given to those countries who had committed national, local professionals within the country setting, and with links to engage health policymakers and government officials for developing a sustainable program. And then focus was also on having an infrastructure that could support the collection and transport of samples and perform confirmatory testing for screen positive cases. And access to treatment, as Diane has mentioned, remains a topmost priority. So several first in-country meetings were held in the last year, and several are planned. And what is the small success that has been achieved so far in Dominican Republic, as an example, is approval of legislation in 2023. And Dominican Republic is now moving to implement neonatal screening. Then in South Africa, after the in-country visit by the task force members, recommendations were developed for establishment of a national advisory panel for biochemical newborn screening. In addition to that, funds have been created for implementation of a pilot project for congenital hypothyroidism, and there's a plan in place to complete it, to develop it into a national funded program. So things are moving, and we are hopeful that with this, change will become. So I take you to this example of Pakistan, of taking this journey of establishing a newborn screening program there. And Pakistan is among the LMICs with population which ranks 5 in the world, and it has one of the highest birth rate. The healthcare infrastructure in Pakistan is under provincial control, and majority, like 70% of the healthcare is governed by the private sector. and there are NGOs and philanthropic organizations, and only 30% is by the public sector, which is the government. Pakistan continues to have high neonatal mortality. And despite a lot of effort by the government and WHO, the neonatal mortality did not show a significant decline as compared to the other countries, and the average global neonatal mortality decrease, as you can see in this graph here as well. And when we analyze the cause of neonatal and under 5 mortality, we see that inherited metabolic diseases are not considered in the workup of sick newborn, whereas many of these conditions are being presented as hypoxic ischemic encephalopathy. So it is proposed that there are additional factors in Pakistan that need scientific exploration. And one of this is such as cousin marriages. And according to the data, more than half of all marriages in Pakistan occur between first cousins, and the burden of genetic disorders due to cousin marriages and its impact on the overall newborn mortality is currently unknown. And therefore, it is proposed that newborn screening can bring an answer to this solution. So now, if I take you through this journey of newborn screening in Pakistan, two pilots have been actually conducted under state. In Punjab, the first pilot was conducted in 1995 and between 1995 to 2005, whereas in Sindh province, it was conducted in 2020 and 2022. But none of the pilots were materialized and achieved the intended outcome, which was to implement the newborn screening at the district level. However, in the Punjab province, some in the private hospitals continue to offer free of cost screening. The incidence of congenital hypothyroidism in this cohort is 1 in 1,300, whereas the incidence from the pilot that was conducted in Sindh is not available. However, both the provinces now have legislation which is essential to have newborn screening. So then there is another organization which is an NGO, and they are doing newborn screening since 2016. And they have screened more than 63,000 babies and about to reach the target of 70,000. And the incidence in this cohort is 1 in 1,079. And 70% of this funding is coming from friends and family through fundraising events. So then this pilot, so we had two pilots, and this one pilot again at Aga Khan University, where I work, was also conducted using serum TSH. And this was between 87 and 1987 and 89. And out of 5,000 live births that happened in AKU, 5 congenital hypothyroidism cases were identified with an incidence of 1 in 1,000. And after that, screening continued with a serum TSH assay. And an audit which was conducted 20 years after on this serum assays again found that 78% of the children were screened out of the children who were delivered. And the incidence of the CH in this cohort is 1 in 1,600. So from there onwards, serum testing was available. Serum testing was available at Aga Khan University, and it was in 2016 that we decided to move to this technology of dried blood spot specimen. And a feasibility was developed, and we followed CLIA guidelines for developing a newborn screening system. And then, and 2 years after, going through extensive review, coordination between different stakeholders, it was 2018 that we were able to launch dried blood spot newborn screening. And we started with one tertiary care center and then moved to secondary care center. So far, from 2019 to 2024, number of babies that are screened is 56,000 plus. 963, which is 1.7% of the births delivered, were found to be screen positive, and the follow-up is complete for 63% of the babies. And the confirmed positive is 6.3%, with a mean coverage of 91%. So, taking this as a baseline program, and this is the whole journey that evolved with the passage of time, high-risk testing and newborn screening for CH, CAH, and inherited metabolic diseases at AKU. And this period spans from 2003 to 2024. So, so what happens that initially in 2007, first was the initiation of clinical services, and all related tests had to be sent abroad. In 2013, a biochemical genetics lab was launched, and then in 2018, CH program was initiated. And then taking this as a model, a congenital adrenal hyperplasia screening was started, followed by initiation of screening of 12 IMDs in 2023. And now we have also developed a registry for these disorders. So, so there are some success factors. Screening, as Diane has mentioned, screening is more than a test. There are certain factors like limitations, like this is out of pocket. It's a private setup and patients are paying the test, and access is only across AKUH network. So it does not comply to United Nations Convention on the Rights of the Child Support. So, but it has an impact, and this impact that I share with you is where since 2013 my slides are missing. So within 1 year of having this lab, we were able to diagnose 81 cases, and the diagnostic odyssey that usually the patients were having improved a lot. And by looking at these conditions, most of them are treatable neurological childhood NCDs, non-communicable diseases, and which highlighted the need for NBS. So this is not working correctly. So this audit, but for the expert who is the biggest conundrum is that starts after the diagnosis. And here what we saw that the patients were not being treated properly by the general physicians, and they were not prescribed food supplements. And therefore, a reimbursement model covering diagnosis, disease management, nutrition, drugs, follow-up coverage was needed. And also the awareness, training, and local guidelines were to be developed. So, so there were issues, and a lot of advocacy was conducted. Like, for example, the IMD is out of pocket in Pakistan, and to support treatment from Baitul Mal. Advocacy and ongoing support our patient is still ongoing. Initially, what happened that these FSMPs were imported and they had a very high tax rate. So a lot of advocacy went into this, and after that, but only 10% of the patients are able to receive it. So so here is a sneak peek into rare registry out of from Jan 2013 to June 2023. We have identified 6.6% positive cases, which is very high, and 50 conditions and disorders are being screened. And as you can see from this data that MMA, BTD, PKU, all are treatable if they are diagnosed early. So here we have the barriers to implementing sustainable newborn screening program, and the list that you see here, all are operational issues and can be monitored and addressed if there is a continuous quality improvement process. The main problem, the main barrier, in my opinion, is the lack of political will and commitment and the government support because of several reasons and absent legislation. So there are 10 primary challenges to implementing newborn screening in low and middle income countries. However, if we have committed champions and education of in the local context, with locally agreed guidelines for monitoring the programs, then things can really happen. So I think, in my opinion, the way forward is to strengthen the local leadership and gaining government support and federal support. There are collaborations, teamwork, a lot has been said about it. But the last point that I would like to mention is that local production of the kits, FSMP and orphan drugs will definitely have an impact, and academic industry linkages should be established for low resource setting. Then, and this is an example of from CLAN CLIP project, where local production of hydrocortisone for CAH patients produced remarkable decrease in the pricing of the product. And this is also an example where, using big data and AI, we can do a lot. And this is for the marker, which is 17-OHP for CAH. And as you can see, that laboratories are churning out this data, and targeted interventions can be achieved through this. And lastly, I just want to mention here, because we are running short of time, and so this is the map that I mentioned to you earlier. And this map is available on the ISNS website, and it will have several advantages. Like it will become a centralized resource where all newborn screening activities can be visualized. So I will end my slide after showing this last poster, which was which was presented and received first prize in the meeting at Hague. And the lady that you see here is a very committed scientist who wanted to establish newborn screening program in Lahore, but was not able to achieve the intended outcome. So she handed over all the material that she developed to me. I also attended that meeting and was listening to the speakers, sharing their experiences, decade-long experiences. And I felt guilt because I was the section head of clinical chemistry at that time. And I thought it was my responsibility to bring that technology change that was needed. So it's not only motivation, inspiration, Diane, but it is also sometimes the guilt that you may have when you are not able to perform your responsibility. So this is, things can improve, and we are finishing, and with this.
Thank you very much, Dr. Aisha. It's a real pleasure to hear from somebody who's been really, really, really walking the walk as well as talking the talk. It's now my privilege and pleasure to introduce Professor Aman Pulangan, who is a professor of pediatrics and the executive director of the International Pediatric Association and president of Yayasan Kesehatan Anak Global. He's a professor of pediatrics. He's a pediatric endocrinologist who's got 30+ years of advocating for newborn screening. There have been recently some tremendous successes in Indonesia, and we're so looking forward to him and his team telling us about them.
Thank you, Diane. Yeah, Aisha, you're right. Until 2023, only 3%, 130,000 something baby. And less than 1 year right now, we have 1.3 million baby screening. Yeah, so this is something that, and I remember when I was trained in Amsterdam, my supervisor told me, in Indonesia, you need newborn screening. Why don't you learn about newborn screening? Because in Holland, they are really good, of course. They're a small country. And then they sent me, I forgot the small town close to The Hague. I forgot the name of the town. So I was, they sent me about 1 week to that place. And the person in charge told me, you are the 4th person. There are 3 Minister of Health before came here. Nothing happening in Indonesia. And then it was early 2000. 2012, I was the president of International Society Newborn Screening Congress in Bali. You were there, right? And after that, nothing happening. So I have 7 minister of health, nothing happening. And right now, we have the 8th minister of health to make it happen. I would like to introduce him, Mr. Budi Gunadi Sadikin.
Thank you, Pak Aman. The 8 health ministers. You know why it happens? No. I love to talk. Because I'm a nuclear physicist by training, and my career is 30 years as banker. I closed my career as the CEO of the largest bank in the country. So in front of this table, I have the least knowledge and skill about medical and health. The foolish and the hungriest, if we remember, stay hungry and stay foolish. So I know nothing about this. I even don't understand why the president chose me to be the Minister of Health. The first time in the Republic of Indonesia, the Minister of Health is not a medical doctor. Then I realized, because the first job that he asked me to do is just to execute the vaccination. That is my first job. I was asked to replace the previous health minister in December 2020. I only have 3 years and 9 months as a health minister. I will end my term in the next 5 months on October. So when I received the task of execute the vaccinations, and I'm good at executing. I'm not really good in medical. I know nothing about health, but at least as the CEO of the largest bank in the country, I know how to execute. So we are very lucky that in 1 year and 9 months, I just want to see the numbers, we successfully delivered 453 million jabs at 204 million Indonesians. And I have to share with you, one of my strengths is to lobby to get grant and money. So more than $1 billion value of vaccine, around 120 million doses, I got it for free. From Gavi, Geneva. That is the reason now I always come to Geneva to say thank you to my friend that saved Indonesian life. So ladies and gentlemen, after doing the job for 1 year and 9 months just to do vaccinations, I start realizing after finish, I asked the president, what is my next job? And he said, do the biggest ever reform in Indonesian healthcare system. I realized that I only have 2 years left. And now it's only 5 months left. So what I've done in the last 1 year and 7 months is we set up a national healthcare reform strategy. And after that, we realized we need to change the law. So we did change 11 antiquated healthcare law or healthcare bill into one. And then we realized that we need money. So I managed to lobby syndication of 4 biggest multilateral banks, the World Bank, the AIB, the ADB, the SCB, $4 billion that got approved last December. So and we have start disbursing those $4 billion of money. We changed the law, very focused on primary care, prevention programs. And then we also heavily digitalize the national healthcare systems. That is basically what I've done in one year and 7 months to really act like a health minister, not like the vaccination minister. And now the question is why I'm so attracted to Pak Aman Pulungan argument to focus on prevention, and one of them is screening. The reason typical banker, we are very good in managing wealth of our client. My clients are the wealthiest people in the country. And even they are very wealthy, I still lending them money. So they owe money to me because I give money to the wealthiest elite of population in the country. But then I realized that managing health is much more fun because it's saving life. It's saving life. And then when I start discussing about health from the banker's perspective, I realize that a country like in the US, they spend average 11,000 US dollar per capita per annum, and the outcome is 79 years old average life. As a banker, I love to compare. I see US neighbors, Panama, Cuba, they also have 79 years average life. But you know how much their people are spending? 1,900 US per capita per annum. So I'm very close with the US Secretary of Health and Human Services, Becerra. So I always tease him, when I reach 70 years old as American, I will migrate and change my passport to Cuba. Why? Because I can live as long as the American and spend only 1/6 of the money. Of course, he said, Budi, you cannot compare. Our philosophy is different. Okay, let's compare to Japan. 84 years average life. They spend 4,800. Or even there is another better country, South Korea. 83.9 years average life. They spend 3,800. The best in the world is my neighbor, Singapore. 84 years life, average life, and they spend only 3,200. You know what is the difference between Singapore and United States? The difference is the country with a very cheap or very efficient healthcare spending is the country that focus on keeping their people healthy, not to cure the sick people. That the policy of healthcare is preventive, not curative. When I came to this Ministry of Health, 80% of my budget and my time is for curative programs. I don't blame my predecessor because they're all doctors. Doctors are trained by years to cure sick people, not to keep people healthy, because otherwise you don't have any patients. So that is the reason I'm a man. Because of financial reasons, I believe it will be much cheaper if you prevent rather than you cure. To keep people healthy rather than to cure sick people. The second reason, I met with all the professors and learned about diseases. One of the major diseases that increase very much in Indonesia is cancer. And all of these professor, Pak Aman Pulungan friends always teach me. Professor like to teach, right? Even the minister, they believe they teach. They said, Budi, you have to understand, and they have to use that hand. You have to understand that cancer is curable with the latest technology. You have breast cancer identified early, stage 1, 90% survivability. But when you are diagnosed late in the game, 90% fatality. So again, then I realized that you have to screen earlier because it's not only cheaper, but it's also better quality of life. In Indonesia, by the way, the survivability rate is only 30%. And the reason why, because I understand to diagnose breast cancer, number one killer in Indonesian women is using mammogram. And out of 3,200 hospitals that I have, only 220 have mammogram. So less than 10%. Can you imagine why Indonesian women are never being had mammogram? So they die, or at least they're being identified cancer late. So that is the reason why I'm very committed. And now I have a very powerful pen, like political will. I have political power that I want to move everything, healthcare policy on prevention. Because I think that is cheaper and that is also a better quality of life. And one of them is screening. You have to educate promotions, you have to immunize, vaccination, but you have to do also screening as a key programs in prevention. So it is one of the part of the programs that interests me. You know how I learned screening? First, I learned screening. I am very systematic in a way because I'm an engineer. What are the biggest problem of our children? Oh, we have stunting. 20% stunting rate out of 25 million below 5, which is 5 million children in Indonesia every year stunted. Stunted, if the Pak Aman taught me, if you get stunted, then you will be not as smart as other people. So I have to do screening, nutritional screening on 25 million of children every year. So what we do, we distribute 10,000 ultrasound to 10,000 puskesmas. Before we only have, for your information, we have 34 provinces in Indonesia, and then 514 cities, and then 10,000 districts, 85,000 villages, and 300,000 hamlets. That is our government structure. So 34 provinces or state, and then 514 cities, 10,000 districts, 85,000 villages, and 300,000 hamlets. Our healthcare facilities stop at district level, 10,000. With the new law, I push it down to the village level at 85,000. But before, we only have to screen babies with anthropometry, the nutritional screening, at 10,000 puskesmas. Since 2022, we distribute 300,000 anthropometry, increase from 10,000 to 300,000, push it down to the hamlet level. So they can do screening, not at 10,000 occasion, but 300,000, all digitalized, linked to our information system. And after you screen, the mother will receive a WhatsApp. I signed a deal with Bill Cartwright, the CEO of WhatsApp, so I can get WhatsApp for free. Indonesia love WhatsApp. And then I signed a deal with the chief executive of Google Health, Karen, so I can get a free geotagging services to Google Maps. So Google Maps doesn't only show, Indonesia doesn't only show hospitals or barbershops or restaurant or hotel, but I can show also diabetes level in which cities, which villages, which address, and hypertension, which are the highest. Which one has been immunized by 13 times or which one is only 8 times. So then we have the link WhatsApp. And just last month, I signed with Elon Musk, came to Bali to sign with Starlink. So 10,000 puskesmas is 7,000 island. We have Starlink access, 200 megabps download. So we can upload and have a telemedicine consultation with the centers. So, but I get back to you. So I started with the screening nutritionally. So anthropometry increased from 10,000, 300,000 in the year 2022, and ultrasound from 2,200 to 10,000. We do the screening, everything digitalized. After screen, it's sent a WhatsApp to the mother. And then after that, I realized, hey, this screening is good. Now I moved to another screening, which is actually, I just realized it is under newborn screening. It is, I learned, Indonesia have 4.8 million babies every year, almost the same as population of Singapore. So every year, we have one Singapore, every year, because the population is the same. One for every 100, 48,000 have congenital heart disease. And 25% of it, 12,000, have a severe congenital heart disease. What do you call it? Asianotic or cyanotic, heart disease, where the blood is mixed. And they have to be operated in a year, otherwise they will die. Our capacity every year is only 6,000 operations because we don't have enough pediatric cardiac surgeon. So 6,000 babies die every year in our country. So then I feel very, very sad. So that's why I said, why don't we do, screening for this, whatever, congenital heart disease? And I said, yes, Budi, you can do it. By having a dual oximeter in every puskesmas. So when the baby is born, you can measure one in the hand, one in the feet, or whatever it is. So that's why in 2023, we finished distributing oximeter to 10,000 puskesmas and teach all the general practitioners how to measure and put it in our central database and identify the national reference hospital of heart surgery and distribute the babies. So that is the first newborn screening without realizing that this is newborn screening. Pak Aman told me, Budi, there are physical and chemical newborn screening. This is newborn screening. Oh, I don't know that, but okay, let's do it. And then after that, I met Pak Aman. So I did the congenital heart disease screening before Pak Aman. I met Pak Aman, he complaining to me, I met with 5 or 6 health ministers, then do nothing, why didn't you do this? And I think I'm a very logical person. I think you are right. So let's do this. The recipes, we do a lot of things you can see on the screen, but it doesn't really matter. The recipe is because I do a weekly conference call with all the party involved. the minister himself, because I love to do, I love saving lives. I think that is the best wealth in the world. So we do weekly calls at increase from 100,000-ish to 1.3 million-ish in a year. And less than 1 year. And I have to put a point, yeah? I don't like average. Bankers don't like average. I said, what did you do this week, last week, and what your commitment next week? So the average now is 50,000 per week. I'm yelling to them every week. So this year I will yelling to them every 2 weeks because I want to increase from 50 to 80. So before they do 0 to 50 in a year, I want to increase from 50 to 80. So the average this month, or actually average December last year, is already 50,000 a week. So I said to my team, if you do nothing, you sleep, you're lazy, 50,000 multiplied by 52 weeks is already 2.5 million. So if you see 1.3 million now, and my team talk to me, Pak Budi, my target, I will increase almost 100%. To what? To 2.5 million. I said, that is a very lousy target. It's increased by 100%. Don't fool me on mathematics. I'm nuclear physicist. You already did 58,000 per week. So if you are sleeping, you can multiply by 52. It's already 3 million. So if you put the target 2.5 million, are you cheating on me or what? I said, everybody can do it because we are already at 58,000 a week. So I should give you a target 4 million instead of 2.5 million from 1.3 million, because easily we can get 2.5 million because our run rate every week is already 50,000. Now I want to push them to reach 8,000, 80,000, so we can reach the 4 million mark babies, which is I'm happy to retire. And after that, I realized from Pak Aman that we can add additionally the congenital adrenal hyperplasia and also G6PD. So I want to start this year, the CAD and also G6PD. And without talking to Pak Aman, again, without talking to Pak Aman, I just talk now. Everybody come to see me, Budi, because you are so passionate on screening, can we do something also for the eye? So I've decided to buy the ophthalmoscope for 10,000 puskesmas. Start will be delivering with the World Bank money starting next semester. I didn't realize that this ophthalmoscope is actually can be used to newborn screening because they can identify what they call it, the macrophthalmia, microphthalmia, coloboma, and cataract. These are the 4 biggest congenital eye diseases. And I just realized from Pak Aman. Pak Aman said, Budi is already inserted in WHO standard now. And I already bought the instrument and already trained the doctors, but not for children part, but for adult, because adult we have the cataract. And the new thing that Pak Aman told me is about the ear. So physical is ear, heart, and eyes. Chemical is congenital hypothyroid, congenital adrenal hyperplasia, and G6PD. I hope when I retired, this 6 newborn screening will be done. The ear, we need an OAE. I don't understand, auto whatever acoustic emission devices. And we have decided it will be start being equipped to 10,000 puskesmas starting in 2025. And the budget is already included in a World Bank loan. So last thing that I would like to do, I want to expand this further. Actually, I'm also studying about thalassemia. Indonesia is thalassemia belt, the north and the south. And we can send what call it labs to darah, blood chemical analyzer and hemato analyzer to 10,000 puskesmas that we can identify thalassemia. We are working with several biotech companies to do genetic testing because now we have a lot of new next generation sequencing machines also there. So hopefully it will be done next year. I will close my speech by saying thank you for all the support. And let me quote this. As a banker, I'm working with money, with the wealth of my client. But now I'm a strong believer that the best wealth is health. Second, in China, there is a Confucius saying that when you want to be prosper for 1 year, then you grow rice. But if you want to be prosper for 10 years, you grow trees. But if you want to be prosper for 100 years and more, you grow people and make sure the babies are safe. Thank you.
Thank you so much for one of the most inspirational speeches I've heard for a long time. And I hope the policymakers in every country are listening and hearing you.
Okay, thank you, Pak Budi, for the government and political perspective. I just want to remind you, from my clinical perspective point of view. Just want to make it quick. Next. Okay. Oh no, this is my slide, please. Okay. This is the story. Well, we start from nothing, and we got 1.3 right now. And Pak Budi said that, we will reach hopefully maybe 4 million. This is in Indonesia. We have 17,000 islands. So this is quite difficult. And right now, we only have 12 center lab. So we have to add it. Refidi, you should add it, I think. We have a lot of other islands that we need it. Everybody knows, we come here to Geneva for SDG, and SDG number 3. This is the most important thing, that non-communicable disease, environmental disease, universal health coverage, like what we do today, walk the talk, Mr. Terror said, universal health coverage. So quality, affordable medicine, vaccine, and also call for more research development. Of course, increase health financing, strengthening capacity, countries' health risk reduction and management. So this is the global newborn screening to provide early asymptomatic recognition, I think, of a defined panel disorder where early treatment is effective. NBS is also becoming available in many developing regions that we have to make it for all the world. Right, Kate? I think this assembly, I think after this, we have to make something like statement. Yeah. And like our minister said, we're going to go to congenital hypothyroidism, congenital adrenal hyperplasia, congenital heart disease, hearing loss, and probably maybe we go to beta thalassemia, probably metabolic disease and eye. We're talking about component of education, screening. This is quite difficult. Integrated, implemented within public health program, considering economy, political, social, and cultural aspect. We have it in Indonesia. Right now, we have 38 provinces, about 272 million. It's quite difficult to reach all of them. So justification, prevent long-term health outcomes, of course, detect disease. NBS panel is widely available in most developed countries, but not in developing country on low middle income country. This is one of our paper, I think, when we start to convince the previous Minister of Health, but they still think, they don't believe it, because my paper said, all of our patients who came to our clinic in our hospital, in Cipta Hospital, the IQ mostly below 70. So you can imagine, Pak Budi, what can we do with below 70? Below 70. Yeah. And the performance IQ, just because of what? Because we don't have national newborn screening at that time. Just because of that. You can imagine how many people right now with the IQ below 70 in Indonesia. So I just want to bring you with these two cases of my patient in newborn screening. One from my public hospital, my teaching hospital, same age, IQ 37, and the other one was born, the same city in Jakarta, the IQ above average. So what's the difference? This is not fair, right? They're not chosen to be born at the different hospital. So who's responsible is this? Someone has to say something, right? See, you can see this one below 37. This will be burden to all parents, all countries. So the problem is why? Because just delay diagnose. We just need like 2 weeks or 1 month. After that, we can treat them. So the IQ mostly will be below 80, and most of them also will have growth retardation. This is the challenge for newborn screening. Well, I think this has been explained by our Minister of Health. Long way, almost 30 years, of course. Yeah, 7 Minister of Health. So he's the 8th Minister of Health. And we have the relaunch in August, Pak Budi. Yeah, I forgot. Yeah, because you had COVID during that time. And you couldn't come today. Yeah, and then after the relaunch, we started. So 2024, like you said, we will have congenital hyperplasia, G6PD, and everything. So this is the data, I think, Aisa already explained it completely about the number about other country. And people always think, Indonesia, I think there is no hypothyroid or adrenal hyperplasia. But see this paper that we published. For CH, we have it CH1 in every 2500. But for CAH, we have 3 out of almost 1200. They will die from adrenal crisis if we don't know about CAH, congenital adrenal hyperplasia. And this year, we will start with the pilot project in Java. But after that, I think we should start to other country because they will die. They don't have to wait. Or the other thing, probably with these disorders of sex development. So we prepare already about the medicine. We have the medicine. The medicine is not expensive. We have Genison and also Sitnacort. Yeah, thanks God. This is quite difficult also to convince our FDA before and our local company, because no big company, I don't want to say the name, wants to produce the fluorocortisone. And one person from local company, finally they want to produce it. And also the hydrocortisone, also from Indonesian company. So this is, well, the paper before Carmen and Brett paper that we published it. This is the problem. I still have 6 more minutes. No problem. Refusal from the family, we still have it. That's why we have to increase the awareness about this technical difficulties in sample collection. That's why we need you, Diane, Aisa, and Kate. You have to come to Indonesia, give training. I already told my Minister of Health, we are willing to welcome you to all the lab, we have to increase the knowledge. Referral system, and then limited availability of filter paper. That we have to overcome this and difficulty recalling the patient confirmation test. This is another problem in Indonesia. Why? The geographic, we are the biggest archipelago, 17,000 islands. I think it's quite difficult. I think we have to increase the center of the lab, Mr. Minister. Otherwise, already approved. Okay, thank you. Because otherwise, it's quite difficult. 12 lab, we have to recall, and I don't know. It's quite difficult, 34, okay, 34 lab center. See, Diane, you have to come every twice a year. Okay, our approach is establish urgency of newborn screening, ensure availability and access, involvement of clinician. We have to involve all, not only pediatric endocrinology, because we only have pediatric endocrinology in 15 provinces. So to educate one pediatric endocrinology, we need 2.5 years, and also we send it to abroad. So I think we have to do something to educate also general practitioner and also general pediatrician. Otherwise, I don't think, we can handle it. National training healthcare professional, national campaign, awareness of the acceptance, we have to do that. So this is the past challenge. We know it. And I agree, Aisha, Mr. Minister, political will. This is the most important thing. Lack of government support, yeah, limited program infrastructure before, low commitment of the hospital to contact. Logistic, of course, transport, people cannot afford screening because in my private hospital, we do 6 screening, Mr. Minister. All the grandchildren of all our president born in our hospital, in the private hospital. But this is quite expensive. That's why, the government have to provide this. People cannot afford. Conserve misconception among patient and family. Current progress, PH screening become national program. Thank you. 12 government-based laboratory, private plus private hospital. PH screening covered by national health insurance and screening more than 30,000. So 50,000 right now, Mr. Minister. What, 60,000? 55 to 60,000 samples. Yeah, this is, I think, already that. This is the story of that. So plan for 2024, I think already mentioned by Mr. Minister, and also we already published it in 2024. And Carmen and Terrell also already put this, Mr. Minister, our planning in the new published paper that Aisha was. ICE, okay, we will add it to ICE. Thank you. Okay, so lesson learned. Prioritizing NBS as it given an opportunity for every babies to live and grow healthily. Commitment and harmonious collaboration between stakeholders, overcoming technical barriers, increased number of lab, training health worker, Indonesia, 5 geographic location, integration NBS in the healthcare system and program, increasing awareness for mothers and family to consent for screening. We still have refusal about almost 40%, Mr. Minister. So let's strive to ensure all newborn are screened. Thank you, everybody. And also, I would like to give special thank you to Kate. You make it happen. To UN, everywhere.
Paman, can you go one more slide, please? Just to show the number. Next slide. Actually, next slide. Next slide. No, next slide, Pak. Jangan mundur, maju. One more.
Habis.
One more. Terus aja, Pak. Slide-nya aku. Yeah. Next slide. No, next slide, Pak. Next slide. I just want to show the chart because I don't understand on this one. Chart aku di belakang. Di belakang. I love this one. I love this too. This is the one. I think Prof. Aman have the energy. You can feel it, right? Pak Aman has the energy to convince the ministers, so the minister will pass part of his energy down to the troops and see what the Indonesian has done. So I'm very proud of you, Pak Aman. Thank you. You saved many Indonesian children.
Okay, thank you, everybody. And I hope also we are here from International Pediatric Association. We have Dr. Navin Taker, I think, outside, the president of International Pediatric. We will support newborn screening. Also, our elected president, Professor Joseph Haddad from International Pediatric Association. And Dr. Kate, also the co-chair of the Access to Medicine Working Group in International Pediatric Association. Thank you, everybody.
That is the most amazing story, and it makes me quite emotional to think of how that passion has come through and how maybe more countries should not have doctors being Minister of Health. Doctors are good at what they're good at, but you have clearly been very visionary when it comes to the bigger picture. Very, very well done. But thanks to our panelists this morning, and we're going to move on now to talking about a different condition, although you've been alluding to thalassemia, but we're going to talk about sickle next. So thank you very much. Right, who have we got? What are we doing? We're global director of the global assembly community. We can professional. Right, so we're five behind. Yeah, no, that's fine. So we don't have Jane or Wilma, but Lee is the global director. Yeah. So we'll start. So if I just introduce you, and I'll leave you all the time for the session, and you can speak yourself, or you can have your colleague speak, or and you can manage that. And so together you will have almost 1 hour. Oh, no. So we're going to have Dr. Anshu as well. Yes, he's running late. Okay. So I'll introduce you, and your colleague can have that 30 minutes. Right. And come on, sit up here with us. Are we about starting again? So, welcome back to our next session, which is going to focus on a condition which we don't talk about so much, but which is really, really important, and really important in some particular parts of the world. And I'd like to introduce Leah Mamo, who is the founder and executive director of Africa's Sickle Cell Organization, which is an organization that envisions a world where people with sickle can survive and thrive with sickle. And so she's going to look after the next part of the session. She's going to speak herself and work with her colleague here. So thank you very much, Leah.
Hi, everyone. How are you? I have no slides. So this is us. pardon our session. We have a change of plans to the people who are going to be speaking on this session. Okay, so because we do not have Dr. Jane and Dr. Chukuma, I am going to introduce my fellow colleague, who is Dr. Isaac Odame, who has a list of accreditations, the credentials around sickle cell, and is the best person to speak about sickle cell, I think, in this World Health Assembly. Second to me. Anyway, my name again is Leah Kilenga Masamo. I am the founder and executive director of Africa Sickle Cell Organization, and I am a person living with sickle cell disease. And I hope to educate you more about sickle cell disease and what initiatives are happening in sub-Saharan Africa around newborn screening for sickle cell. Okay? I don't think I have any slides. Yeah, okay? So how many of you in the room, I know you're a handful, know about sickle cell disease? 2 people. Okay, majority. Okay, so I will give you a bit of statistics and then my personal story. So sickle cell is defined as the most common genetic hematological disorder in the world. And it is the most common, the most neglected health issue to date. Sorry for bringing you the spotlight, Dr. Aisha, but there were top 4 diseases that you said you prioritized. Within the Africa region, less than 2% have been diagnosed, right? Screened. And on the list, there was no sickle cell. Okay? So sickle cell was a disease that was diagnosed or defined over 100 plus years ago. You would have think that in 100 years, we will have made advancements in medicines, in healthcare infrastructure, in newborn screening, in research around sickle cell, but it hasn't happened. Hence, even the Daktari, Dr. Aisha, did not mention sickle cell in sub-Saharan Africa. So why is that? Currently, 515,000 children are born in Africa, globally, with sickle cell annually. But up to 90% of those do not make it to their 5th birthday, meaning we are losing majority of these children, either due to lack of newborn screening, which majorly due to lack of newborn screening, and preventable complications and disabilities that do not see them live long lives. In contrast, adults with sickle cell lose about 50 years of healthy life in the poorest regions of the world. Out of 75 years of an adult, 50 years are taken away for an adult like myself. But my story is different. So I was born in a family where 3 of the 4 children had sickle cell. My oldest, so 3 girls and 1 boy. The first girl, she was diagnosed at 1 year old. She presented with multiple complications. She was in and out of the hospital. And it was only until a research organization came into the country that she was referred and she eventually got her diagnosis at the age of 1. Unfortunately, she did not make it. And she succumbed to sickle cell-related complications at the age of 4, fulfilling the statistics that I just told you. The older sister that I follow was diagnosed at 1 month old. She presented very early, and since my older sister already was diagnosed, she was diagnosed, and she was linked to care early. But she had a complex childhood, dealing with complications like stroke, dealing with cholecystectomy, removal of the gallbladder, the malfunction of the spleen, a vascular necrosis. However, she got the opportunity to go to study in the US, and now she enjoys better healthcare because they have prioritized sickle cell for adults there. For me, I was diagnosed at the age of 3 months because my older sister was diagnosed, I was diagnosed, and also my younger brother. My younger brother does not have sickle cell, nor carries the gene, so he's just there in case maybe we need a bone marrow for transplants. But for me, I presented early. I was linked to care early. I did not present with a lot of complications, hence why I'm here. Healthy enough, very little disabilities. You wouldn't even know I have sickle cell unless I told you, right? Yes. Which is the thing that we want. So newborn screening helps. Because my older sister did not get that privilege, she succumbed to the complications. My older sister almost succumbed, but she kind of was supported. So newborn screening allows people like me to have good quality of care, to prevent complications, disabilities, infections, as well as lead good quality of life up to our adult years. And thirdly, it does help our parents. Sickle cell, one of the biggest characteristics of sickle cell is it is highly stigmatized within sub-Saharan Africa, and I'm sure across the world. Due to years of neglect, health disparities, health inequities, and even lack of knowledge and information in the communities, we see that people associate sickle cell to witchcraft, to ancestral curses, to gods have finally put a scar on our household. That's why our children do not survive. Hence, people do not seek out care. Okay? So newborn screening gives parents relief and allows us to understand what this patient, what this baby is suffering from. Imagine treating or going in a hospital in and out, not knowing what you're treating. That is what majority of the parents in sub-Saharan Africa are facing, which causes blaming within the internal household, where the father says, no, I don't know why this is not my baby. Or the communities, like we need to perform some spiritual and cultural cleansing, rituals to rid this demon from this home. So it does not only help me be healthy, it helps my family, my mother and father, who were able to create an enabling environment for me to survive and thrive because they were informed. They went a step further, okay, to seek out doctors for the numerous complications sickle cell brings about, to give me care, to link me to hydroxyurea, wherein I can be able to speak about sickle cell with no complications. So the other challenge, why I started Africa Sickle Cell Organization, this is the biggest reason, is because as I matured and as I grew up as an adult, the health system, the health infrastructure did not mature with me, right? I am so happy that we are now focusing on newborn screening because while I was being born, there was no newborn screening. As a matter of fact, the biggest therapy for sickle cell, hydroxyurea, was only available when I reached the age of 16, which had why my sister had many complications. She started it later, I started it a bit earlier. But now we have a little infrastructural development that allows children to be given medicines that can help them to survive. So Africa Sickle Cell Organization was started from a pain point. I was in a crisis. For those who don't understand what a sickle cell crisis is, it is severe intractable pain, one of the most common symptoms of sickle cell. I went to a private hospital in Nairobi. You would think Nairobi, Kenya has good healthcare for sickle cell. It does not, I assure you. The doctor asked me, my dear, what do you normally do when you're in such a situation? I was like, what? Shouldn't you tell me? So at that point, I realized there was no healthcare infrastructure. There were no adult doctors. As a matter of fact, I stayed with my pediatrician until I was 21. Yes, it is that serious. There were no complex, chronic support for my reproductive health as it developed. for my cardiopulmonary health as it developed, for my osteoporosis as it developed. So newborn screening not only allows the patients to survive, the parents to be informed, but governments to plan for the patient throughout the continuum of care. Because as much as we are focusing on the newborns, the age of 0 to 5, how are we planning for the adults who mature and grow and will need care at different stages of their lives? Okay? So that is the one thing that I feel as an adult, as much as we are talking about newborns, helps in the long term of things. How do we stay ahead of the curve of sickle cell or all these other diseases? How do we prepare for all these other conditions in future? In Kenya, it is estimated 14,000 children are born with sickle cell each year. And of those 14,000, the economic burden is 1.6 billion Kenya shillings. Yeah? So newborn screening allows us to save 1.6 billion Kenya shillings, which is 0.02% of our GDP in Kenya. However, we do not know the economic burden, the social burden, the healthcare infrastructure burden of those adults that we do not know how many they are who are out there. Okay? So I am going to, how many of you know about the Pareto principle? Yes? You don't know? Okay. The Pareto principle states 80% of consequences stem from 20% of causes. Okay? So a small percentage of causes have outsized consequences. For me, this is how I look at newborn screening. Newborn screening, or lack thereof, has outsized consequences to the health and well-being of patients like myself, at newborn, at childhood, at adulthood. And it has outsized consequences to the healthcare system, to communities, and to households. If we do not have that component, all these other systems are affected. And the country and the governments are unable to prepare themselves for this. So what are we doing? So I want to bring your attention to, last year, during the World Health Assembly, the World Coalition of Sickle Cell Disease was formed and was launched. This is a coalition of private, public partners who are at the forefront of solving sickle cell in the world, but most importantly in low and middle income countries. And when we are saying public-private partnerships, we are also looking at the patients, okay? The patients are also in the conversation because people like me inform the policies and the decisions that you make, how they affect my life, how they will affect my life eventually, okay? So we have a session tomorrow at 5 p.m. at the Intercontinental. I invite you to come and see what we are doing with sickle cell. One of our biggest priorities and our major, we have 5 priorities. The top most priorities is early screening and newborn screening and diagnosis for sickle cell. Without screening, we cannot be able to prevent all this other barrage of problems. Secondly, there are cards on the chair. I don't know if you noticed them. So we, as the Africa Sickle Cell Organization, we are partnering with the World Coalition of Sickle Cell Disease. We are creating a sickle cell disease community of practice because of the historical, I will say, neglect, and largely the focus being on children and adolescents and newborn screening. Who is looking at the adults? What are we doing about the adults who eventually survive, who have complications, those who are not detected early? So the community of practice is patient-led, where patients and practitioners have a discourse about the challenges, about the experiences of adults with sickle cell, with the healthcare system, with the policies, with health financing, and we are welcoming as many partners as possible in the ecosystem of sickle cell to join this community of practice and to join the coalition of sickle cell disease and to attend our event tomorrow to learn more. So I will leave you with one last thing. Our family is complex. We lost one sister. My other sister is well off and is privileged, but I am here because sickle cell is not a discussion topic in many conversation rooms, but we are changing that. So I welcome you to join us as we change that for people like myself and people who are not privileged to attend meetings like this. And I want to welcome Dr. Isaac Odame to please give us a complete understanding of sickle cell and why newborn screening is very essential for sickle cell. Thank you.
Thank you very much, Leah. It's always powerful when you have a person with a lived experience talking about any disease entity. The authenticity, the passion with which they talk is very impactful. When it comes to sickle cell disease in sub-Saharan Africa, it's a public health problem. 1 in 50, 1 in 100. That's what we're talking about. So you need a public health approach. It's not a rare disease, it's a common disease. And when newborn screening has been done as pilot projects in sub-Saharan Africa, health policymakers have been shocked. And the question they ask is, where are all these children? It's because they die so early. I think the current publication of the burden of disease, global burden of diseases, is saying that sickle cell disease is ranking probably among the top 12 NCD causes of mortality around the world. And in Africa, it is very, very important to tackle sickle cell disease. So what it is that it is a genetic, chronic, inflammatory, endothelial disease, which means that no organ is spared. It's the commonest cause of stroke in children. It causes neurocognitive damage. In fact, the brain is the most vulnerable organ in sickle cell disease. It causes excruciating pain, which is recurrent. And sickle cell pain is worse than labor pains. So just imagine a child right from the onset having labor pains 3, 4, or 5 times a year and needing potent analgesics to control them. They are also susceptible to infection because of poor spleen function. In fact, that's what gave the impetus for newborn screening, because penicillin prophylaxis and pneumococcal vaccinations can prevent early mortality and pneumococcal bacteremia. And that's why the impetus was that if you diagnose them early in life and start penicillin and pneumococcal prevention, you can prevent the early mortality. Malaria, actually, the sickle mutation really spread because carriers of the sickle gene have better protection against malaria. So over time, in all malaria endemic regions, the sickle mutation has thrived. So it's in sub-Saharan Africa, the Arabian Peninsula, the Indian subcontinent, and then areas of the world where people have migrated from these areas. So if you have sickle cell disease, you are resistant to malaria infection. But if you do have malaria, your mortality rate is going to be very high. And so in sub-Saharan Africa, malaria-related severe anemia is one of the common causes of death. And you're talking about a region where access to blood transfusion is very limited. So before the child can get blood transfusion, they have died from profound anemia as a result of malaria. So they need malaria prevention as well, apart from preventing infection. Thanks to Gavi, the Gavi initiative has been indirectly impactful on sickle cell disease because many countries in sub-Saharan Africa now have preventive vaccination as part of primary immunization. So whether the child is diagnosed from sickle cell or not, they benefit from preventive vaccination. And so that has been a very impactful intervention, although it was not directly intended to tackle sickle cell disease. But apart from infective deaths, they also die from organ damage. Acute chest syndrome and pneumonia-like complication leads to respiratory failure, and it's a very high cause of mortality. And so you need a disease prevention, disease-modifying treatment, which is hydroxyurea, which is what Leah spoke about. We think that by the time they are 1 year of age, they need hydroxyurea therapy. This is a medication that was synthesized in 1869. It's a generic medication which is so impactful in reducing the complications of sickle cell disease. And yet the world has not found a way of making hydroxyurea easily affordable and available to every person who needs it. In Africa, the only country that manufactures it locally is Nigeria. And even there, because of low demand for the medication, because of lack of education, lack of training for healthcare providers, no systematic screening, no programs to really identify those who need the medications, the manufacturing capacity is way below what is needed to be able to address the problem. I think the African continent should have several countries that manufacture hydroxyurea. I think that it should be easily available and affordable, being a generic medication that should be easily provided. So for Africa, newborn screening is so critical. But while we're waiting for newborn screening infrastructure to develop, I propose that there's another way to screen, and that is by using point-of-care testing that is integrated into vaccination programs. Because vaccination programs have had high coverage in sub-Saharan Africa. And I think that if we can integrate an intervention like point-of-care tests, for which now we have very good tools that within 10 minutes can tell whether the child has sickle cell disease or not. I think at every encounter with the healthcare system, the opportunity to screen for sickle cell disease must be taken. And in a very rural, remote area in Ghana, we have used point-of-care tools to identify children with sickle cell disease while they go for vaccination or go to child welfare clinics. That infrastructure is already existent. So while we are building newborn screening as a potent infrastructure to be able to screen for multiple disorders, I think we ought to screen also using point-of-care tools that are integrated into vaccination programs. That way, we'll get there faster, and most children will be detected, and the early preventive strategies that prevent mortality can be put in place. Hydroxyurea needs to be freely available, and I think we need a global program to make this medication affordable and available. That is the way we are going to be able to address sickle cell disease, which is a public health problem, mainly in sub-Saharan Africa. India has taken a bold step of wanting to eradicate sickle cell disease in 25 years. They've taken a bold step to screen everyone, to also counsel people before they get married, to offer prenatal diagnosis, and in that way to reduce the burden of the disease. And I think what happens in India is something that is going to be closely watched because some of the methods they use can be translated more easily to sub-Saharan Africa. These are my few comments about newborn screening for sickle cell disease. It's an imperative because it's a public health problem, and SDG 3 will not be achieved in sub-Saharan Africa if sickle cell disease is not addressed. Thank you.
Thank you both very much for those very insightful. Right. We're just going to just close with talking about sickle cell for a minute. So thank you so much for your very insightful and thoughtful comments and showing how really important it is for all the bits of the system, for families, for the healthcare to work together. And I'd especially like to pick up for people who are designing programs, how to link screening to other healthcare events. And I think that's really thoughtful of you to be talking about vaccination and saying, take the opportunity when the baby is coming for something else. So, very good. So now it's my pleasure to introduce Dr. Anchi Banerjee to you. He is I have to read this because it's so long, Director of the Department of Maternal, Newborn, Child and Adolescent Health and Aging. Isn't that pretty well all the health for all the world for the World Health Association? And it's a real honor for him to be with us to talk about how the WHO can support newborn screening. Thank you. Look, I'll tell you, that's your slides. That pointed at the screen moves the slides on, and I'll give you 5 minutes, and then 1 minute. Is that all right?
5 minutes?
No, before you.
Oh, before
the end.
Yeah. It's shorter. I see. Thanks very much, and it's a pleasure to be here, and particularly to talk about this subject that I think we're very interested in taking forward. And so we're going to look a little bit about prioritizing birth defects, screening, diagnosis, and management, and looking at the whole continuum of care. And maybe first of all, to situate this a little bit within the global context and why it is important to look at birth defects. First of all, of course, we have the Sustainable Development Goals, and looking at, for example, the under 5 mortality and the newborn mortality targets. We know that it will be difficult to achieve these by 2030 unless we also start looking at screening and managing birth defects. And so the targets that we have are for neonatal mortality to have as low as 12 deaths per 1,000 live births. And when it comes to under 5 mortality, have as low as 25 deaths per 1,000 live births. And at the next slide, I'll show why this is important and where countries are situated in relation to that. And so we have a number of key initiatives that are working together jointly as partnerships, as global partners, but also ministries of health, civil society, together to see how we can meet these targets. The first of that is the Every Newborn Action Plan, which was launched at the World Health Assembly in 2014, and which has now merged with the Ending Preventable Maternal Mortality, because so much of the work for a newborn is related to the care of the pregnant woman. So therefore, we decided to look at this together, but also looking at what we call the Child Survival Action, which is looking at how to accelerate progress for children after the newborn period, so from 1 to 59 months. As well, of course, all this fits within the global strategy for women, children, and adolescent health. And so we know that until to date, let's say, a lot of the work has focused on look at that continuum and providing care for children with birth defects as important strategies to achieve these child health targets. So if we look at the under 5 mortality and the contribution of birth defects to under 5 mortality, within the neonatal period, it's 10% of all neonatal deaths that are contributed by congenital anomalies or birth defects. Within the under 5 period, it's 6%, or let's say from 1 to 59 months, it's 6%. So in total for the period of children under 5, it contributes to 8% of overall mortality. But we know that it also contributes to mortality in the age group from 5 to 19 years. And so we have around 1.2% of mortality due to congenital birth defects in that age group. So overall, a major contributor to under 5 and child mortality. But at the same time, here we're only looking at mortality, and we're not even looking at the cost of management, the loss of disability lives, adjusted lives years, etc., etc. And this is the slide that sort of shows the progression of the contribution of birth defects to the overall under 5 mortality. So if you are in an area with still high under 5 mortality, where a large part of the contributing mortality factors are diarrhea, pneumonias, malaria, as we just heard, it's the overall proportion of birth defects to the mortality of children under 5 is still quite low. It's like less than 5%. But as countries progress and as they start eliminating causes of disease of under 5 mortality due to infectious diseases, then the proportion of newborn deaths actually increases. And so in the higher income countries, we see that coming close to 30%. And so if we look at where the SDG targets are of around 25 deaths per 1,000 live births, then we see that, you know, the contribution of birth defects to under 5 mortality is already coming to that 10%. And as countries will progress, it will just become more. It's not more in numbers, but it's proportionally more. And therefore, if we start looking at how to address this and supporting lower middle income countries in addressing this. So in 2010, WHO had a resolution that was passed, and that really requested WHO to work or to start looking at what to do around birth defects. The first thing was really to initiate and monitor population screening programs, or to support population screening programs, such as screening of newborn infants. Secondly, to look at integration of approaches, and we just heard about the integration, but to look at integration of approaches to the prevention and care of birth defects into primary health care, with an emphasis on maternal and child health, so to look at that continuum. To identify successful models of care that can be applied in low and middle income countries, to develop expertise and build capacity, and to promote international cooperation. And this year, we're going to have another resolution to look at how to accelerate reduction of maternal and child mortality. And one of the requests also to countries has been, again, to look at how to integrate birth defect screening into their general programs, and including management and care. So hopefully that will be passed during next week. We haven't got it yet, but in the verge of making. So what has WHO done based on this resolution? Based on this resolution, WHO has looked at surveillance and estimates of burden. So birth defect surveillance toolkits have been developed, and we have defined case definitions. We've looked at development of country-level estimates of birth defects, and we're actually, and I'll talk about that later, looking at renewing those estimates or redoing them. On the prevention side, of course, there's been, of course, always a big emphasis on folic acid fortification and supplementation, but also just talking about immunization, let's say, looking at elimination of congenital rubella syndrome and congenital syphilis, as well as supporting antenatal care and postnatal care in order to be able to have proper counseling, to have ultrasounds to potentially identify birth defects, as well as postnatal care. And when it comes to screening, diagnosis, and management, we've looked at developing a framework for countries to plan initiatives for screening, diagnosis, and management of birth defects relevant to their context. Because, of course, different diseases or countries are in a different level whereby they can address different diseases. Sometimes, you know, you should start with 1 or 2. Others can take on more. So looking also at the cost of the batches for metabolic screening, depending on the cost, you can decide to screen for 2 or 3, or you can screen for many more. And to look at how to support that screening, diagnosis, and management into maternal and newborn child health programs. So on birth surveillance, we've come up with guidance that really focuses on visible birth defects. It looks at aligning to the resolution from 2010. It's a joint effort together with CCC and ICD-BSR. And it looks at three components, or it has three components. It's got a manual for program managers. It's got a quick reference handbook, and it's got a facilitator's guide. And this one is going to be released, a revision will be released later this year. And we're also looking at a digital adaptation kit to improve surveillance by providing content requirements for a digital tracking and and also to support decision-making systems for birth defect surveillance in primary healthcare settings. So I mentioned that we're updating the estimates. This is work that's being done through a technical working group. We've asked many partners to join the technical working group in order to contribute data that is available. So we have our CA code, which is a partnership that looks at releasing and availability of UN interagency that has released, let's say, data recently. And this has a time series from 2000 to 2021 for congenital anomalies as a combined category. And the first slide I showed, the pies, let's say, are extraction of the data from those series. Secondly, also, we're looking at cause-specific estimates. And this technical working group is now looking at case fatality data for specific settings and standards of care in order to provide a really comprehensive overview. So we're using gold standard registry data that is being collected from global registries, such as the EuroCat, the RECLAM, the SCAN, ESCAN, the ICBDRS, and others. We're also looking at prevalence data from countries without data, at prevalence data from countries which don't have good data, and looking at how we can collect information in order to have a series of systematic reviews targeting those low and middle countries in order to identify data that we can put into the model that will be used for the birth defect estimates. And we have a range of conditions that are detectable and preventable and treatable that we're really focusing on as part of these estimates so that it becomes operational afterwards. And the Born Healthy Toolkit will also allow countries to do their own kinds of need assessments. The responses on prevention that we have focused on, I mentioned earlier, the nutrition, the folic acid fortification, and last year we had a resolution at the Assembly on nutrition that really also focused on folic acid fortification. We're looking at expanding access to rubella vaccination at country level. And when it comes to sexual and reproductive health, we're really looking at mother-to-child transmission of syphilis. It's part of a triple elimination goal, elimination of transmission of HIV, syphilis, and hepatitis during pregnancy to the child. And we already have a couple of countries that have been certified of having achieved those goals. So it is doable. So how do we move the needle towards, let's say, towards better screening, diagnosis, and management for birth defects? First of all, we'd like to have a strong focus on prevention, such as fortification and surveillance, both of which are important and need further strengthening at country level. Not all countries have been able to put up a folic acid fortification program, for example. Giving the epidemiological transmission, which I showed a couple of slides earlier, many low-middle income countries are experiencing this transition whereby the proportion of birth defects will increase. And therefore, it's important for them to start thinking and to start focusing on screening, diagnosis, and management of birth defects in the newborn, but within their own context, looking at what they think that are the priority congenital anomalies that they feel that they can address. For newborn screening for birth defects, we'll need well-functioning established programs. We have well-established functioning programs in high-income countries, but it's really and that can screen, more than 50 birth defects. But how do we translate this into low middle income countries? And so this is where it's important that we really localize, let's say, action in order to take that forward. And that depends on sort of, what are the most prominent ones, what is the health system that they have, what can they deliver within their health system, and maybe start with universal screening for 1 or 2 conditions, and then build their program based on that. And finally, the largest proportion of birth defects are of course seen in low middle income countries. Just looking at where they are, we know that prevention is of course reducing in the high income countries, reducing the numbers, but in low income countries, we're still behind there. So why isn't it important? Why are we as WHO taking this step to start looking at the continuum of care from screening to diagnosis and management? I've just highlighted the overall global burden, but also the burden as part of the transition, and how, as countries will progress, this will become proportionally a bigger problem for them. And therefore, treating children with birth defects early gives the affected child the best possible care and the best possible chance to lead as healthy a life as possible. And it's important to not only look at this from, let's say, a mortality perspective, but also all the social stigma that is around children and families having birth defects. In many cultures, it's seen as, there's a lot of stigma around it, let me say, put it like that. There's blame that is put onto the parents, there's blame put onto the woman, and so it's important that we really are able to not only address this, but also provide the support and provide the explanations in order to reduce this kind of blaming culture on parents, and particularly women, potentially. 90% of the deaths, as I mentioned earlier, already appear in low and middle income countries. And so this is going to be higher proportionally, definitely. And children with disability from birth defects are, of course, exposed also during their life course to multiple inequities. And they have more limitations in functioning, poorer health, and shorter lives. But we need to be able to provide, from an equity perspective, a human rights perspective, a right to health perspective, we need to be able to provide that kind of care. And by including birth defects in the global and national priorities, we can therefore also fulfill the SDG commitments of leaving no one behind and improving situations of millions of affected children and families. And so it's really important that we start thinking of this within a systems approach to improve survival and well-being of children with birth defects. So some of the key considerations to look at when it comes to diagnosis and management. It's important to scale up equitable and universal access to newborn screening in all countries, but with a particular focus in low and middle income countries where most of these birth defects occur, so an equity principle. But to embed also this screening, diagnosis, and management into routine services, and of course under the leadership of the Ministry of Health, we want to ensure that we avoid parallel actions and vertical approaches, and it's really integrated into healthcare, because this will also allow identification much better. And looking at linkages across levels of the health system, and also involving, of course, the private sector, where relevant, to ensure that every child with a positive screen has access to a confirmatory diagnosis, and the family has the opportunity to have access to information, support, and a management pathway in case the diagnosis has been confirmed. We know that, of course, in some cases, which are rare diseases, it's difficult to come to a final diagnosis, but the support needs to be provided to families in view of that. And so when it comes to screening, we would like to highlight that, it also includes clinical screening. So visual birth defects, important to be screened at birth for So to do a visual screening at birth, to look at structural defects such as club feet or also orofacial clefts or potential problems with the eyes, but also looking at a hearing screening for newborns, particularly in premature babies and in low birth weight babies. Screening for defects of sight once the child should be able to see, but also using pulse oximetry in order to screen for critical congenital heart disease. And of course, during the COVID pandemic, many countries have had support with the provision of supplies for oxygen provision, but also pulse oximetry. And so that can be used now also more widely, not only for patients with COVID or children with pneumonia, but the tool is there, so it can also be used for screening congenital heart disease. And then, of course, also looking at biomedical screening, such as through the blood spot, to look at congenital hypothyroidism or hemoglobinopathies, etc. So from our perspective, we were wondering which, there are so many birth defects, what should be sort of the criteria to look at to identify maybe which ones would be the first ones to really focus on. And so we were thinking that, first of all, we should also have effective treatment options in place in order to look at that continuum from screening to diagnosis to management. So look at the local context, which ones are the ones that countries are dealing with. Can they be accurately diagnosed within the country is important, and is treatment feasible within the country context and within the context of the health system? Or in both cases, can capacity be built in order to put diagnostics capacity and management capacity in place? And also, of course, to look at the fact of whether it has a significant impact on the life of the infant and the child, and and that it has a reasonable cost for the health system. So maybe just to look at that, we know, for example, that it's easy to put in place universal screening through a blood spot for congenital hypothyroidism, and management is available, is easy, is cheap, and has a major impact on that child. But when you look at the overall burden, then it are, for example, the congenital heart diseases and the neurotubal defects, which are causing the biggest, which are the biggest contributors to mortality and morbidity. But the interventions are more complicated once you have diagnosed them. And so is it feasible for many low-income countries to put surgical programs in place or not? And so this is the balance that countries need to put in place. And there are examples where this has been done. And so countries can learn from each other in order to see how they could, in cost-effective ways, take this forward. Sorry, I think I still had to talk to this slide. And this slide really just highlights that it's important to look at that continuum and not look at some of these components in isolation, and that we need to link the screening to the confirmation of the diagnosis, having the availability to refer the person, being able to provide treatment, whether it's medical or surgical or corrective, and provide follow-up and long-term rehabilitation support. So yeah, it's in order to set up a program, you really need to look at that whole continuum. So at the moment, we have a strategic technically advisory group of experts for maternal newborn child, adolescent health and nutrition. And they asked us as WHO to develop a framework that would support countries to plan and implement initiatives for newborn screening, diagnosis and management. And so we're looking, of course, taking a rights and a values-based approach, but looking at a systems approach to really see how systems could integrate newborn screening, diagnosis and management. Looking at, we've set up an expert group that will convene later this year for the first time in order to, and that also includes parents and people who have experience of birth defects, so that we also have, let's say, the demand side and the patient view incorporated in our thinking. And it's supposed to focus on preparing how health systems can deliver services to across this continuum. It's not supposed to focus, so it's a framework, and therefore really looking at how we can support low middle income countries to decide themselves what they would like to take forward, and not so much focusing on one or another condition, but really looking at it from a programmatic approach. So some of the issues that we will consider within developing this framework is placing the newborn screening, diagnosis, and management initiatives in the context of the newborn transition. The newborn transition meaning the countries that are moving from high mortality to lower mortality, and so that will help countries identify what they could focus on within this continuum of care. Looking at a few initial conditions in the absence of routine health information systems data on birth defects across these low middle income countries, because the standard for the routine health information systems is coming from the high income countries. But also look at other information in order to see how we can work also together with pediatric and neonatal societies in country to sort of identify what would be priority conditions in those particular countries to take forward. Of course, this needs to be looked at within a whole of society and a whole of government approach. So also looking at collaboration with ministries of finance, national health insurance systems to make sure that this would be reimbursed, work with disability groups, civil society, and professional bodies, as well as really looking at what would be the additional human resources, competencies, needs that need to be addressed, infrastructure needs, referral pathways to diagnosis and management, etc. Really looking at this from a systems approach. And of course, reducing misinformation and stigma in the community. So surgical capacity is definitely an area that contributes to the management, whether it's for cleft lips or congenital heart disease, etc. And so there's already been quite some engagement with the pediatric surgical community to look at how we can strengthen that component as well in management of the birth defects. Just to say that as WHO, we have recommendations in our postnatal care guidelines on newborn screening that look very much at, already mentioned, the universal screening for abnormalities of the eye, and universal screening for hearing impairment. But so we have clear guidelines for that. So important, again, in order to get this on the agenda of all countries, we have a universal health coverage compendium, which highlights the interventions that countries can select from in order to include in their essential health services package. And so birth defects have not been prioritized for many low middle income countries from a policy perspective, but it's important that countries can start looking at that. And we need to also make sure that we highlight the burden of the birth defects as a collective group, because if we split them up into individual diseases, let's say, then the overall burden becomes very little, very small, let's say. But if you look at them as a group, then it's really highlighting what the overall burden is. And so our UHC compendium will include birth defects interventions into them, so that ministries can look at them and look at how they can be part of their essential package. We're starting to have discussions with our technical units in our medicines group, and to look at what could be included in the essential diagnostic list, as well as what could be included into, I think that's the next slide, no, into our essential medicines list in order to support this agenda. And so, final slide, in summary, newborn screening is going to be a priority in the coming years as countries progress, as their health systems strengthen, and as the proportion of birth defects will become a larger proportion of the under-5 mortality. We need to ensure that we scale up equitable and access, but also ensure universal access to newborn screening, diagnosis and management, include different stakeholders to do so, and jointly really move forward this agenda. We are, I think it hasn't come out yet, but I hope next week we're coming out with a commentary which was the result of the meeting in Chile last year in March as part of the birth defects work and highlighting this particular area of work and why it is important. So unfortunately, I think it's not yet out, otherwise I'd have been able to put the reference there. But thank you very much.
Thank you very much, and thank you for including a broader perspective on birth defects, including defects in body chemistry, for example, which are often not thought of. They're often thought of as being more physical things, but nice to be able to know that you're including the biochemical defects as well. Although, to be fair, many of them are much rarer than the physical defects. And so looking forward to seeing that document and seeing how countries can be encouraged to do what we've all been talking about in this session, which is fitting the screening into the rest of healthcare from a funding perspective and from a practical and operational perspective as well. So thanks to all our speakers on this panel. It's been really inspiring. Thank you very much. Now, some of you may not be as familiar with Kate Armstrong as some others of us. I think you've heard Kate mentioned and referenced in many of our talks this morning already. Dr. Kate is the president and the founder of an organisation called CLAN, which is Caring and Living as Neighbours, which has had an original focus on outcome and treatment of children with some specific body chemistry disorders like CAH, but now is really focusing on helping overall improve the outcome for these children, and that includes newborn screening. So we've been very delighted to welcome Kate into the newborn screening community. And for those of you who may not know, the International Society of Neonatal Screening awarded Kate the Lerber Award for initiatives in developing screening, and we were very proud of being able to do that for Kate. And now she's going to talk to us about her rights. I'm getting a bit tongue-tied here, Kate. About the importance of a rights-based approach in newborn screening.
Thank you very much, Diane. And thanks so much to all the wonderful speakers. That was such a great and important session on sickle cell disease, and very grateful to our speakers for sharing. And Dr. Anshu as well spoke about the importance of a rights-based approach. And so I'm hoping to share a little bit of information about a new resource that we hope people will find quite helpful. Those in the room have received a handout, and there should be a link to it in the chat as well. Also want to acknowledge all of the people online who are watching and joining in. Thank you for your questions. We have some of those on Slido, and we'll be discussing those in the question and answer session. But to this flyer, we hope this will be a useful tool. Just by way of context, as Diane said, my name's Kate Armstrong. I'm the president and founder of CLAN, Caring and Living as Neighbours, an Australian NGO that's really committed to equity for children living with chronic health conditions in resource-poor countries. We have been working since 2004. This was the very first congenital adrenal hyperplasia CAH club meeting I attended in Vietnam in 2005. And we spoke to 54 families. There are an estimated 100 children alive with CAH in the country at that time. And we consulted with 54 of them and asked them, what do you need for your child to have a good life with CAH in Vietnam? And the parents told us very clearly. They identified 5 things, and they said, if we can have these 5 things, our children will have a good life. They want affordable access to essential medicines and equipment. They want education, not just for themselves and their child and their health professionals, but also the government and the world. They want everyone to know. They want research, advocacy. They want the best medical care for their child, unsurprisingly. They want strong support groups for encouragement and just lived experience, knowing other people who've gone through the same thing as you. And they want freedom from poverty. They want to be able to afford to care for their children themselves. So we've been using those 5 pillars in our strategic framework for action, taking a human rights-based approach. We identify all children living with the same condition as part of the same community. So we have members of the sickle cell disease community here today, the CAH community, and how do we work with that community and as many different stakeholders as possible to help the children have the highest quality of life possible. So as you can see, a rights-based approach is really important to the work that CLAN does. And in 2015, we started our very first flyer for children living with congenital adrenal hyperplasia, but we've since adapted it for type 1 diabetes, epilepsy, osteogenesis imperfecta, rheumatic heart disease, nephrotic syndrome, across a range of conditions, and we have them now translated into 6 or 7 different languages. The flyers take a similar approach each time. At the start, it's really, the purpose of the tool is to help children and young people who are living with chronic health conditions, NCDs, to be able to advocate for themselves. This one introduces people to the UN Convention on the Rights of the Child. And then as you open it up and you look at those 5 pillars that the families mentioned, what do the different articles within the UN Convention, there are 54 articles, how do they relate to what families are saying they want? And interestingly, all the things families say they want are covered in this. And we're hearing the same themes, hydroxyurea from sickle cell disease community. Dr. Anshu spoke about the essential medicines list for children. Dr. Rahman spoke about fludrocortisone, hydrocortisone in Indonesia. We're all speaking about the same things. We partner with as many different champion organisations as we can to share the message, choose some hashtags people can use in advocacy, and at the back just some basic statements, information to help with raising awareness. So we hope that this tool on newborn screening will be useful to people with their advocacy efforts moving forward. And yeah, just please let us know if you'd like to be involved. We're looking to launch this on the 29th of May at our upcoming SIDS4 conference side event. That's the Small Island Developing States side event. So we can still make changes. We welcome people to get involved, and we hope that it helps your community speak about the importance of newborn screening and the rights of children to life and health. Thanks, Diane.
Thank you very much, Kate. Now, we've talked a bit about organisations which are involved in supporting development of newborn screening in various jurisdictions, but there are also very many individual institutions worldwide that are working to, often in country-to-country partnerships or institution-to-institution partnerships, to support newborn screening initiatives. And I'd like to share this one with you from Australia.
Salutation from Sydney, Australia. My name is Enzo Ranieri and I am the head of Department of Newborn Screening at the Sydney Children's Hospital at Westmead. I am absolutely delighted to have been asked to provide a background to the involvement of the Sydney Children's Hospital with this initiative to expand neonatal screening within the Asia-Pacific region. I wish to acknowledge Professor Veronica Wileys as a champion of newborn screening in the region over many decades, providing expert advice and support for programs from as far as the Philippines to China, Malaysia, and Indonesia, to mention just a few. She continues to provide this volunteering work to the present day. It is an honour, a privilege, and a pleasure for the newborn screening program in New South Wales to continue to provide this service to the region in the form of an expert opinion, and importantly, the training of specialists in the technical, scientific, and clinical areas. Most recently, this collaboration has been in the form of a donation of a genetic screening processor, GSP, manufactured by Revity to support Indonesia in the expansion of its already successful program. This instrument automates biochemical and immunoassays used in newborn screening for conditions including congenital hypothyroidism, congenital adrenal hyperplasia, and galactosemia, not to mention many more, all done from a dried blood spot, and to other activities to enable the highest quality testing. This donation would not have been possible without the input from Revity, a company and partner with a long history of support for new and developing programs worldwide. We acknowledge this generosity and will continue to work with Revity, and including other newborn screening companies and professional organizations like the International Society of Neonatal Screening and the International Federation of Clinical Chemistry and Laboratory Medicine to support initiatives to bring newborn screening to more of the world's newborn babies. Thank you very much for this welcomed opportunity to talk to you today. Thank you.
Thanks very much for that, Diane, and thanks so much to Enzo for that, and to Revity for that wonderful tip. I know that the team at Children's Hospital Westmead are really passionate about working with partners around the region, and I'll speak about another partnership that they're forming with colleagues in the Solomon Islands as well in a little moment. But I wanted to invite Dr. Naveen Thacker to come and share some words, if that was okay. Can we move on to the next slide? Oh, there we go. From the International Pediatric Association. I was just going to start by sharing a few words on the consensus statement, and then the IPA, the International Pediatric Association, is such a mammoth organisation with such enormous reach, and very interested to hear about the work that the International Pediatric Association feels that paediatricians have to play in this space. I guess I'll briefly just introduce this consensus statement though. In 2021, we had colleagues from Zimbabwe reach out, and they were wanting help with their CAH community in Zimbabwe. And by that stage, since 2017, very few children have died of CAH. None really have died of CAH in Vietnam once they're diagnosed. And we knew that we were seeing such tremendous change in Vietnam. We didn't want to trickle change out. We wanted to be really bold. So Mates for Kids is a coalition of like-minded organisations really committed to reducing the preventable mortality associated with CAH by 30% by 2030. That aligns us with SDG 3.4, which is calling for a reduction in mortality associated with NCDs. So we put forward a briefing paper to WHO, and we're mindful that we don't have long to go before the SDGs are delivered, 2030. So what are we going to do? We've been coming together every quarter, partners from the Americas, Africa, Europe, the Eastern Mediterranean, Southeast Asian and Western Pacific region, talking about actions that we're taking to achieve this goal, which we think that we can do if we improve access to essential medicines, strengthen CH communities, and scale newborn screening. We're hoping that this consensus statement helps us really have a shared language around what do we mean when we're talking about newborn screening. As Dr. Anshu said today, it's not just blood spot screening, it's more than that. It's systems-based, as we heard from Diane. So we're really interested to know, paediatricians, what's their role going to be? So I'll hand over to Dr. Fakhanin.
Thank you, Kate, and thanks for the opportunity. It was very interesting to listen to everyone since last 2.5 hours. And to be honest, I was not very sure what I'm going to speak, but I know now what can be done. And it was very inspiring to listen to Minister of Health from Indonesia, and that has reminded me, and it was like a good story. And I will tell you also one story and what we can do. So first about International Pediatric Association, it's a 115 years old only umbrella organization of pediatric societies representing more than 1 million pediatricians in more than 170 countries, around 175 societies. There is no parallel pediatric society. All the big societies, pediatric society, all subspecialty society, everyone very happily works under one umbrella. Whether it is Indian Academy, Pakistan Pediatric Association, or whether it is American Academy, Royal College from UK, RCPCH, or Australia, everyone under one umbrella. And we are very happy to work together. And you can see our commitment. In audience, we have Dr. Joseph Haddad, who is President-elect, and sitting here from very beginning, Dr. Aman Pulungan, who you heard how he inspired the health minister. So we are fully committed to support newborn screening, and who else will be more worried than pediatrician? Because, we are always, we have to deal with those children and we have to support those children. And, prevention is always better than cure. So what it requires, I can tell you, Kate, that we have great convening power. This is not still, very big issue. First thing, we have to demystify this. It's not just one blood spot. You can do much more. And then you have to make these services available, make it affordable. And that's why I said I will tell you a story. When I was president of Indian Academy of Pediatrics, I was in Japan in a conference where from the Chinese Pediatric Society, they presented how with the help of American Academy, they launched a newborn resuscitation program. So when I came back, I was president of Indian Academy, and I asked, well, do we need that? And what's in our country? They say it's there, but going very slow, and all those mannequins are very, very costly, and we can't, So I said, what do we require? Everyone said we require only up to bag and mask. Not necessarily intubation and everything. It was very, very, made it very inaccessible tool for learn people. First thing we did, we talked to the Laudel and made at that time they were developing a simple mannequin, Neonatal, and we did the pilot testing. We made that available. The first thing was changing the mindset of pediatrician, that you don't require, and we took help of other organizations like Latter Day Saint Charity, and those were the quotes. You don't need clean trachea and dead babies. You need bag and mask. So we made that available. We changed the mindset of the people. That was convening power of Indian Academy of Pediatrics. Now God has helped me to reach to International Pediatric Association, where we can mobilize more than 170 countries. And maybe there may be something why I accepted this invitation and came here, because something is written that I have to do that. So now I know how many people, how many people are trained in India in newborn resuscitation. We started with private sector. I think more than 300,000 or so, and then government called us. You know, you will say that it is very important, government should be on board. If you are doing something good, everybody can see that it can happen. You will get a call from government. And one day we got a call from government, and we worked with them. And in that sector also, we trained 50 training of trainer in 6 months and everything. And my colleague, you know, you have to make it simple, demystify it. And still, even for me, I'm not a neonatologist, but for newborn screening is like, you know, scary. You need a very high cost machine. Even Dr. Joseph was telling that it is very costly. So we have to demystify that. So my colleague, Dr. Panna Chaudhary, he is no more, he used to tell, he explained to somebody, and if you are aware with Mr. our, father of the nation, Gandhi, and he did a Dandi march. So he explained, just to break a rule for making salt. So he explained to him that it's like a Dandi march. Everybody can do it. So if you demystify it, make it available, and then what else? Once you see, as a pediatrician, we are also interested what will happen to those children who need help. So there are good models. Fortunately, it's all coincidence. From here, I am directly going to Nepal for a Pen Plus workshop, where they are demystifying. They are taking in Africa, in so many countries, sickle cell, diabetes type 1, from the tertiary level to secondary level. That's what we need, and we can help at every stage. We are very good in advocacy. We work very, 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 very closely with Ministry of Health in all the countries. And as our, one of our founders, Dr. Dogramachi, used to say, pediatricians are connected to every house, every politician, minister. So we can do that. We are very good in capacity building, and we are very good in dissemination. As I said, we have great convening power. So you have our full support. Now it's up to you to take advantage. You have a good friend, who works with you. Aman, you are working already in one of the IPA working group. Let us do it. It's not a rocket science. So we can reach to everywhere, and our Dr. Haddad and we have a lot of focus on Africa. And I hear from them sickle cell. We have a lot of, so we have a lot of focus on Africa. Very good. We have our, after the Latin America, we have our conference in Africa, first, after many years. Yeah. So we need to work, like I was in Kenya, we do a lot of immunization work there, and I heard from there that we need something on screening, and we can definitely fully get involved. Our focal point will be Dr. Haddad and Aman, and I am always there. So let us do it. Let us take it to every corner of the world, as IPA tagline is, every child, every age, everywhere. Thank you so much.
Dr. Thacker, can you just stay for a minute?
You want? Oh, you want me to?
Well, I just wanted to say something, and that is that people who know me will know that I've got a few stuck record messages, and one of them is about a system, and the other one is about the involvement of pediatricians in newborn blood spot screening. And I believe they have key involvement in policy, because you see the children who have the diseases who will benefit from early detection. So you have the role in, should this country, this place, screen for this condition, and for advocacy for screening. You also have a role in screening laboratories, because they both work out the algorithms that are used one test then another test. And you have a role in setting cutoffs for screening, because you are going to see the consequences of the cutoff. And that's to do with capacity. It's to do with the fact that these disorders are a continuum, and in some environments it might be appropriate only to detect the most severe forms of the disorder. So very important that you work with the laboratories around cutoffs, around notification procedures, so that people hear about the disorders from somebody who knows and knows critically what to do next and leads them on. And then you've got all the roles that you were alluding to in terms of follow-up and treatment. So all parts, really most parts of the screening pathway, you're absolutely critical. And we wouldn't and shouldn't have blood spot screening without you at all the steps. So thank you very much.
Well, it's going to be hard to top that last talk. So thank you so much, Dr. Thacker. That's really inspirational. We will definitely be in touch. The last part that we wanted to share was some good news. I seem to have trouble with this, sorry. So good news about some grants that Mates for Kids have been giving out. And I do want to acknowledge ISNS and Lab Systems, because it was really through the prize that they awarded to myself that we were able to give the first 3 grants. And these first 2 presentations, one from Colombia and 2 from Sri Lanka, are the results of that prize. We've just gone on and given round 2 grants, and we'll be doing round 3 grants later on. So these grants are really community development grants. They're given to countries to focus on those 3 objectives. It could be access to medicines, it could be strengthening communities, or it could be scaling newborn screening. And I mentioned at the start that CLAN's been going for 20 years. We're wanting 30% reduction by 2030 of mortality for CAH. We're planning to give 40 grants by 2030. So 40 grants, they're very small, only 1,000 Australian dollars each, but it really doesn't take a lot of money for absolute champions to do incredible things. And we'll see some examples of that. So the first one is from the Siendo Foundation in Colombia, and their focus was community development. So they held their first club meeting for the CAH community of Colombia on the 10th of March this year. They did a health needs assessment, a very detailed survey consultation with families, and they're working with CAH community members now to identify key priorities for the community and drive change moving forward. Excitingly, the young people have started their own social media platforms, and they're all communicating. They went from people never having met another person with the same condition to now being connected and driving change. And one inspirational young woman spoke at a recent UN event that we held online, and we'll share a video of her talk. Next is Sri Lanka. Amazing pediatric endocrinologists at 2 different national referral centres. They're now working collaboratively at a national level to drive change for the CAH community of Sri Lanka. Translating this brilliant educational resource written by Dr. Agustina Utari from Indonesia, translating it to 2 local languages for the Sri Lankan community. Holding a CAH club meeting, translating other educational resources, consulting with the community, working with the community to drive change. We're proud to announce round 2 recipients today. So first of all, congratulations to Dr. Esther Coble and her team from Uganda. They will be focusing on scaling newborn screening. They're looking primarily at supporting healthcare professionals and scaling the capacity of healthcare professionals to understand and communicate and raise awareness of CAH. Developing some training packages and really looking to help with referral pathways. As we learnt today, blood spot screening is the gold standard, but there's the physical examination as well that you can do to pick up some signs of children with CAH as well. So they're going to be looking at that whole spectrum there. Next up, congratulations to the team in the Solomon Islands, working in partnership with an Australian NGO called Taking Pediatrics Abroad. And Professor Shubha Srinivasan from the Children's Hospital at Westmead. Dr. Titus Nasi is leading the program in the Solomons, and they're looking at piloting newborn screening for hypothyroidism. And we're very grateful to the team at Revity, who we know are already having conversations with them all about this. But this small grant will go towards developing educational resources for the children who are diagnosed, developing up some manuals for health professionals, supporting training for health professionals, and taking Pediatrics abroad does some great work educating and working with health professionals on training. And finally, congratulations to Dr. Phoebe Wamalawa from Kenya, who will be, and we do have a representative from Kenya here in the room as well as Leah, so we've got some support there hopefully for Dr. Phoebe. She'll be looking at enhancing awareness and healthcare capacity around CAH with health professional training, some health needs assessments, and training for health professionals. So we just wanted to let you know about that. We'll probably be announcing round 3 grants on International Neonatal Screening Day on the 28th of June and announcing the winners at the UN Science Summit side event that we'll be running in September. But congratulations to these champions. They're small amounts of money, but we hope to give a platform to people who are doing really, truly incredible, groundbreaking work. Thank you. So we have Slido. I'm hoping my team might send me the Slido in, the access code, so that people in the room can download Slido and get questions in. But we have these wonderful online participants, and they have this. There we go. Thank you. Okay, so we have wonderful online participants who've been sending some questions through, and I hope we have a roving microphone, our IT team, so that we can answer some questions from the floor. So, yes, sure. Now, would we like to start with people? Well, I just want to read one comment from online. I don't have any questions, just pure admiration and gratefulness for Pak Budi and Prof. Aman. Wonderful teamwork and resource mobilisation. We had a lot of positive comments about the work that's happening in Indonesia. And one question that I think might go to Prof. Aman, but anyone else who wants to answer it as well, which I think is a really good question, is how do we maintain political will for newborn screening in the long term? So if someone has an answer to that question, that'll be great. But do we have some questions from the floor to get things started?
Some comments. I have tried to introduce the newborn screening program in one country in Africa. It was extremely difficult. Why? One, it's not their priority. Low middle income country, it's not their priority. They have other priorities like vaccination, primary health care. Second, which is more important, there is no political will. If you compare the national budget of defense in those countries compared to the national budget of health, health represents less than 5% of the GPD. So your newborn screening is very interesting, but you have to, it's a political will. If there is no political will, you will not be able to do anything. And second, it's very costly. It's extremely costly to implement that, the machines and the whole system is a little bit costly. And they are not willing that. This is very important and very critical in those countries. So as you see, as I have seen in your many slides, Africa, the poorest countries where there is neonatal newborn screening. Almost 90% does not do it. Only North Africa and some in the South. So it's a political will. If there is no political will, like Aman has done in his country, there is no neonatal born screening. The other issue is they have a lot of problems in handicapped children. They they have a lot of program in handicapped children. They don't have any social support for those kids. This is also a very hard problem in Africa. Thank you. This is just some comments.
I'd invite colleagues from Kenya. Would you like to make a comment there? And also then perhaps our friends from our sickle cell panel.
Thank you so much. And I'd also like to thank the presenters. Maybe I can first start with the previous speaker. It becomes, and my name is Dr. Gladwell Gadesha. I head the non-communicable diseases division at the Ministry of Health. So it becomes very hard for the government itself to make a case for sickle cell when it comes to prioritizing. That's why we need a lot of voices of people with lived experience, and that's why we become very good friends with Leah there. You need persistently to be reminded, not that we really need to be reminded, but their voices really add to the prioritization of sickle cell in the country. Them telling their stories, them working together with us makes sure that it gets prioritized. And we can tell the story as far as Kenya is concerned, from when sickle cell became a neglected to a prioritized condition. And it also bears the steps of our working with the civil society. It also bears the steps of, we did something with the NCD and injuries, poverty commission, right now called the network, where we prioritized diseases, not just based on burden, because if we prioritize based on burden, sickle cell may not just come as the top, but you also prioritized on the severity and also in terms of what interventions also are available that are cost effective. So that also helped us to put sickle cell on the table. So the next was trying to prioritize interventions, and that's where we also came to prioritize newborn screening. So in just saying that, the speakers who are there in front were reiterating our view or our roadmap of where we want to go. That again, it will be hard as the sickle cell community, the non-communicable diseases community, to try and advance sickle cell interventions by ourselves. And that's why I fully agree, it needs to be integrated with immunization. For us, we're not calling it newborn screening, we are calling it infant screening, because we are prioritizing it we are integrating it with the vaccination, the 6 weeks vaccination being the first one, and then subsequent for those who missed. And then the issue of financing also becomes important. We are now undergoing a transition of financing, but we've also made a case for sickle cell screening to be included in that essential package, because now the country, for us, health is devolved. The same issue about affording the point of care, the strips will then become an issue, but if it's something that is reimbursed by the insurance, it becomes more workable. So we did launch our guidelines last year in June. It's still a work in progress, and I think thanks to the opportunities we've seen, I'm sure we'll get it rolling, because right now it's being conducted in phases, not the whole country. Thank you.
I'd also like to thank Benjamin for his wonderful help today. He's been a superstar.
Yes. Can you hear me? Yeah. I just want to make a comment to your comment that what shall we do if there is no political will? Shall we stop, or shall we make any effort? So I think it is very important, because in most of the LMICs, what we see is lack of government commitment and so many other things related to poor economies and so on. So I think people have to come up with some local solutions. Like for us, it was very difficult whenever we used to say anything about any problem, then there is data. It has to be evidence driven. So there is no data at all. And like groups, small groups, if you look at the literature, there are many groups who are doing, work in silos. And sometimes people are there, and then at times when you take a step and light a candle, then many people come along and they become a powerful group also. So what we have seen, that there is no government will in Pakistan, but then when we started, they become a group and a patient society became active. And they, started playing some role regarding to access to treatment. And so there were so many things. So I think academic institutions and people, NGOs, they should continue to work and should strive, and we should not stop doing because if there's no government will. Because it has so many components also, like education. And even today, if many pediatricians, laboratory people, they have no knowledge of how this system will work. So we need to continue from academic point of view and should not stop.
Leah and Diane, I think we're wanting to say something.
Hi again. I wanted to answer my friend who asked about the political will and the disparities in budgets of health and budgets for security. And I want to appreciate Dr. Gladwell Gatech. I think it has been 10 years of work. I don't know how many years before that I had to take for sickle cell to be a priority, and now it is in Kenya. So there are two ways to, because I've done advocacy for some time, to increase political will. First, the approach that Dr. Gladwell Gatech had suggested of the pressure from the patients, from the people with lived experience, from civil society, that shows government that there is a need for this prioritization within the country. But you have to look at the other spectrum, the global perspective. Because Daktari represents the non-communicable disease department. And for sickle cell, it is categorized under the non-communicable diseases globally. So with the current global prioritization for NCDs, we are looking at the 5 major conditions: cardiovascular diseases, diabetes, cancer, chronic obstructive pulmonary diseases, mental health and neurological conditions. So where do congenital diseases fall? So when the global financing and global prioritization is focused on these major diseases with higher global burdens, then the financing comes from those channels. So the countries at the national level are not able to allocate finances for these specific infant diseases that they are dealing with because they are not getting the finances from the global funders. So that, I think that was the biggest challenge for sickle cell, is because there is no prioritization globally for sickle cell that can be able to create impetus for national governments and regional governments in Sub-Saharan Africa to focus on that. And I think we have to look at political will locally, political will globally. That's why we're here at the World Health Assembly, to give awareness to these problems, to highlight and elevate these conditions, and to understand what can we leverage, what are we overlapping, like newborn screening, how can we be able to leverage for inclusion of those diseases that are not included in the global perspective. Thank you.
My key take home from today really comes from Mr. Booty. And he says it's all about money, and it is all about money. And I think if you're wanting to convince policymakers, you need to be telling them how many people have got this condition in the country and what difference it will make if the detection is early, and how much of the further healthcare costs down the track can be averted. And that's going to be very particular to each jurisdiction, considering what they pay for and what the costs are of the treatment. But putting some numbers in front of people, I think, is more effective than putting stories in front of them. I'm sorry to say.
Dr. Isaac?
Is the quality divided by the cost. And I think increasingly, even in Sub-Saharan Africa, they're beginning to think about the value of delivering that intervention. And I think when you come to think of sickle cell disease and the intervention that is required, penicillin, vaccination, treating febrile illnesses, and hydroxyurea, which is really can be affordable. If you look at the interventions that save lives, the cost is so low for the quality and the value that you're going to deliver. And I think that's how the narrative needs to be framed. Recently, I was with the policymakers in the Ministry of Health in Ghana, and that is what is driving their thinking now, that they think there's so much value in investing in sickle cell disease because the cost and the lives you can save for that minimal investment is huge. And that is what we need to do together with advocacy combined. Thank you.
I would just really support what Leah said, though, about the need for childhood NCDs to be on the post-2030 agenda, the development agenda. Because at the moment, SDG 3.4, for example, really only relates to people over the age of 18. And I've heard Prof. Aman speaking and advocating for children and NCDs to be included in the NCD discourse as well. So hopefully we might, you know, really collectively advocate for a change there by 2030, after 2030. Any other questions from the room? I'm mindful we've reached 4 o'clock, Chair. So any other questions, comments?
And everybody's been very good and patient and been sitting down for 3 hours. So it's really time for a leg stretch and a cup of tea and some less formal talking between ourselves, building up some more bridges as much as we can. So a big thank you to all our online participants, to all our speakers, to all our sponsors. Thank you.
Please enjoy the light refreshments outside. Thanks, everyone.